Much cheaper. Not cheaper, much cheaper.
Good.
Hello and welcome to this afternoon's session. This session is entitled Limb Salvage Pedal Intervention, and I'm going to serve as the moderator. I'm Craig Walker. We have a great panel up here. We have Dr. Krishnan, Dr. Jenkins, Dr. Mohammed, Dr. Soor, Dr. Shroff, Dr. Matajame, and I think I saw Dr. Harkless. I saw him coming in, but I thought, oh, there you are. Okay, good. I thought I'd seen you. I'm just going a little blind in my old age. If we could, I would like to go back to Dr. Davis. He's got some follow-up. Tom, you've tell us what you've done since we left you.
Oh, okay. Well, we're just fixing that proximal segment there right now. What we'll show you is this. So what we found out was, this was our final picture here of the foot, I think. Let me just take, I think this was the final picture actually right here. So there's the AT coming down. You can see it sort of wraps around there and fills a little bit of the PT. It's not real brisk flow, but that's why I think we got to fix that inflow of the popliteal segment. But certainly the problem was that mid-tibial problem that we, I don't know if you recall that right here, I think it was. Because that's when I put that catheter back and I just started injecting as I withdrew back. You can see this is immediately right after the stent. You can see the stent right there. And so it actually opened up quite nicely with stenting that portion of the vessel. So I think that was the major problem that we had right there. So now we're going to try to fix that inflow of the, you can see there's a stent, and sorry, this was I think the before, this is the picture before when I just took a picture through my catheter as I'm pulling up my catheters at the top of the screen. So that was the problem in the mid-tibial. Then when we put that stent in there, you could see as soon as we put the stent in there, we had flow. So that was our limitation there. So we just blew it up and down there one more time again. You can see what we had was that spot right there. It came down all the way down to the tibial. Right now, what we're going to do, I'm debating on whether to put a short stent up there or not. I'm just going to actually atherectomize this again. I think we only made one pass or two passes with the atherectomy device, and I think that was probably one of the problems that we had. So I'm just going to, and you can see the proximal cap is, I'm just going to take a quick picture of it right there. So we're gonna just do a little bit more atherectomy there and see if we can clean it up a bit. Okay, going down.
Yeah, I think that's a smart approach.
See if that'll.
So Tom, that area that you put the stent in the tibial was right where the tibial was occluded before. Is that right?
Yes. Well, that's where we had the problem. Keep going a little bit further. That's where we had the problem where it was the cap, where it was occluded there. Yeah, that was right at the cap. And, you know, even when we threw the atherectomy device down there and did, you know, multiple balloons, and it still was there, you could see that one spot that we had that I showed you. So I think that was our biggest problem, because as soon as we put that stent in there, we had flow down the tibial, which, you know, obviously was our problem. So I think that's what really helped me, was putting that catheter all the way down there, just injecting dye and pulling the catheter back, you know, from the pedal arch down all the way upwards. And then that's where I found that certainly where we had the problem. So we're just gonna take a couple more cuts here, and we're pretty full here. So I'm just gonna take a quick picture here now. Let's see if I can get it off that knee prosthesis again. That looks better. I think I'm going to take a couple more cuts there. I think we're going to really work on that spot there. This is already filled from what I just did, so go ahead, grab that. So we'll make a couple, I think we'll just make a couple more cuts there, but you can see it's already cleaned up quite a bit. So I wouldn't be opposed to stenting it, but I just.
So Tom, I think
What
from
would you
here,
put here? Would you put?
I think from
what
here
would you-
we
what
can
kind of
see
stem would
that
you
you're
guys
gonna get a great result. You have a very nice channel, and can follow this up. Perhaps to get on schedule, if it's okay with you, I'd like to move on to our next case. Is that okay with you, Tom?
I'm sorry, I missed that, Craig. What would you say?
Yeah, I was saying we can now see you've got straight line linear flow, and you're going to get a great result as you stent this. Would you mind if we move on to the next case? Would that be okay with you? You've done a lovely job on a very tough case.
Absolutely, Craig. Thanks a lot.
No, thank you. Big hand of applause. Great job. Next, we're going to go over to Dr. Jack Chamberlain in Elk Grove. Jack, can you hear us? Okay. Okay. Yeah, it's just going to be a second until we're connected here. So that was certainly a great example there of why you have to look at inflow, why you have to look at outflow, of Eric's points about sometimes using side hole catheters to see where your problem is, or by inflation. Certainly identifying your sites of problem are very, very important, and often very short occlusions stop all flow, and you can see how helpful it was to define the site. Hi, Jack. We see you just fine. Can you hear us?
Hey. Yeah, can you hear me okay?
Can hear you fine. This is Craig Walker. We've got a panel up here.
We're going to turn down Junior Wells just a little bit here, and we'll wait for you guys. Sorry. Hey, you guys can hear me okay?
Yep, just fine.
All right. Well, we have an interesting case here today. 86-year-old gentleman who came from an outside wound center. He'd been having trouble with wounds on his right foot on the lateral medial part of the forefoot, and really not getting anywhere. They did do an angiogram in the cath lab over at this other place, and they got to about halfway down the leg, and there was no runoff, and they said, really, there's nothing to do here. So they came to us as a second opinion. You'll see here in the pictures what they were talking about. So if you want to show our cine here. So what we have here at the beginning is a popliteal lesion first, pretty significant. That might have been worth fixing alone. But as you see, as we get to the bottom of the picture here, I think this went to the next one already. Things aren't so pretty here. Basically lots of beautiful collaterals, and the anterior tib is closed at the top. Tibioperineal trunk is a very tight lesion, and everything's closed. And down below further at the foot, fortunately, the posterior tib and the dorsalis do show up by this cascade of collaterals. So it's kind of a mess. We took a little side shot here, REO 11, to see if we could see the takeoff of the posterior tib. And we think we do. I don't know if you can see it there, but after that, what now looks like a closed tibioperineal trunk, centimeter down, half, comes over. It looks like we have a lumen for the posterior tib. So what do you guys want us to do?
Open this vessel, of course. So you're thinking that this is in the distribution of the posterior tibial, this angiosome?
Well, I think that it's actually probably two of them. It's I think the posterior tib will do most of it if we can get the bottom of the foot and the two plantar branches. It actually would. This is the medial and the lateral part of the forefoot are probably fed by the plantar branches of the posterior tib. So yeah, I think the posterior tib's probably the best one to try to get.
Yeah, I actually think you've got reasonably good choke vessels too between those two. I think that you've got connection between the dorsal and the plantar loop here, and I think any vessel you can get right here would be great. And so I would try this first from an antegrade approach, going down, see what you can get, and if not, I would stick retrograde and come back. Rest of the panel, any concept, any thoughts? Okay. So I think that's the consensus of the panel.
But I think I saw distal runoff to peroneal. Was it peroneal or posterior tibial?
Posterior tib and dorsalis.
Yeah, they both.
Can we look at the distal runoff one more time?
Yep. Let me find it here. Hang on a second. I'm out of order here. There we go. So
I think that's the peroneal that we see distally. And that's the peroneal.
You see a branch of it there crossing them.
Yeah, if that's the case, that would be the target that I would try first. It looks like a pretty large artery extending down to the plantar artery, so that would be a good artery to go after.
But Amir, in this case, with all the collaterals that you see in here, you would accept any of them that you would get into, would you not? If the wire started to go down one, would you not accept any of these vessels?
But you have to look at to see which artery is workable, which one you have a better chance to recanalize. I see a distal piece of posterior tibia as well, but it seems that the peroneal has a much longer segment of reconstitution. If you go on the later phase of the arteriogram, you see a pretty long segment of that. But of course, depends on which one from above you can get to.
Sure. I'm taking the position in the argument later that we have in our debate that you need angiosome-directed therapy. But here I must tell you, in a case where the choke vessels are not shut down, I think any of these vessels here are very, very, very important. Okay, I'm probably helping lose my own debate in just a second. But I think first I would take whichever vessel I could get here, and then I'd go back and try to open up more than one of them. But and I often find in a case like this, to avoid collaterals, I'll actually come down and lead with a catheter, like a 4 French catheter, rather than lead with a wire. And the reason is it will avoid the small vessels coming off. Most perforations that occur in a situation like this do not occur from the main vessel. They occur from you getting into micro branches, and you simply don't recognize them. By going with a 4 French catheter, you avoid that. Is that the panel's opinion?
One other thing I would do, Jack, before you commit to any of these approaches, put a catheter in the popliteal artery, do a couple selective injection in oblique position, and see which one of the arteries proximally is amenable to catheterization.
I was about to mention.
Yeah, that's what this picture is.
I think.
Yeah, none of them is really helpful.
I think the most.
They're not beautiful, but you can see the posterior tib start.
It's more important than how the length of the distal reconstitution is the proximal part, because we're choosing the antegrade stick.
Yeah. Often, once you get across one and you get one vessel open, you can open them all. A lot of times that's the case as well. These popliteal trifurcation lesions are tough. Once you get one of these open, it often paves the way for the others as well. And I would typically, in true limb salvage, try to open up several.
Jack, this is PK. I agree with you. I think the posterior tibial forms the entire arch and the dorsalis pedis. I think if you go after the posterior tibial and are successful, you're going to probably give yourself the best chance of healing this wound. I mean, with what Amir is saying, I think that's a great idea too, but I think that would be my secondary approach rather than my primary approach.
Yes. All right. Well, what we did first, based on this picture, was we did try to wire from above, and we got actually down without much resistance farther than I expected. And this is a picture kind of taking a picture through our catheter within the first part of the posterior tib. This is at an angle, REO 11. But afterwards, closed, the wire did not behave very well, and we didn't, we seemed to be going outside the vessel. So we went ahead and stuck the posterior tib, and this is where we are right now. Let me get another picture here. The posterior tib was pretty chunky and calcified, crunchy, and sorry, I'm trying to find it. Here's our picture, I think. Yeah, so here we are from below in the posterior tib. Mm-hmm. So we thought that probably it's very interesting to see these collaterals. Retrograde picture, we almost, I think we get all the way up to the teepee trunk there, really. So he's been working on these a long time. So our goal was to try to wire retrograde from here, and if we can get through that, go ahead and treat it.
Great idea. Jack, let me ask you, did you access using angiography or ultrasound?
Oh, yeah, we used ultrasound. We have the handheld ultrasound, and you could easily see the artery and the veins next to it, so that's what we did. Okay.
And what wire are you using now?
This is a America Bro 3. And we're going to see if we can drive up there a little bit.
Jack, did you leave the antigrade wire down just to give you kind of a target to shoot at?
Exactly. What I did is I left the catheter. We have a Miracle Bro. We have a Trailblazer down there. And we left that in the good part of the vessel up above.
Now, I personally, when I'm sticking these, I like to go, Cook makes a 2.9 French sheath, and one can connect a TUI to this sheath, and you can give drugs, you can do injections, you can look at this. And then they make a compatible, 018 compatible catheter that goes with that. And one can use that to support your wire. As you know, that will let you get across in exchange for whatever wire you wish. But the second part is you can make your wire much stiffer by simply advancing a catheter on the outside of it. You give columnar support strength to your wire, and it gives it greater penetrance. Sometimes it improves your steerability. All of those things are nice. I really like this CXI 018 system coupled with a V18 wire in this situation for crossing, and then I often will change that out to an 014 wire. Now, through this 2.9 French sheath, Cook actually now makes a balloon that will fit through this so that you can actually treat these lesions. So you can keep your sheath size to no bigger than 2.9 French. It says 4 French on the system, and that's looking at outer diameter, but a sheath is measured by the inner diameter, what fits through it. And so if you look at a 4 French sheath, it is much bigger than a 2.9 French sheath. And so it's very important to not be occlusive, and Jack just already told us this vessel is calcified. You could see it was diseased. I think staying as small as possible here is crucial.
And Greg, as you know, the Spectranetics also makes a nice access needle as well. So I think now that the field has expanded to us, attempting more difficult access points such as this, looks like you're through there, huh? I think it looks like there's more and more equipment.
I think we've wired our other catheter.
Great.
On purpose, of course.
That's the way it should go. So, Jack, what's your plan now with this? How are you planning to treat this? Are you going to capture the wire or treat it from below? What's your thoughts?
Well, I think this might be a good one for the Diamondback pilot burr from above. We probably could do the micro one from below if I put a sheath in. Since we're in this other catheter, I think we'll exteriorize the wire, put a Viper down, and just use the Diamondback from above first and go from there. What do you guys think?
Jack, I'm curious, just why did you choose the Diamondback in this case versus some other form of therapy?
The main reason is there is some diffuse calcification, but also I can get a small channel fairly safely at low speed. And then after we get debulked a little bit, I really wouldn't mind just doing a long balloon inflation, maybe use one of Matarjme's expensive balloons, and just sit on that for a while. It's a very long lesion. We know the restenosis is quite high, but without a drug-coated balloon, I'd probably do that.
Yeah, I like laser in this situation just because I think there could be some old thrombus up top. But I certainly would not argue with the CSI here either. I think it's a reasonable approach at this point.
Yeah, I actually thought about the laser as well, and just because of calcium, I thought it might be worth using the drill.
Yeah, except I really think, especially if we look at some of the recent publications on where this calcium is, if you're not doing maximum debulking, rarely does that get in the way of the laser, because it's typically medial-based calcium. And I think right now we listen to a lot of stuff that says if there's calcium, you need a grinder. Always, that's not the case. It is certainly, a grinder is better if you've got 360-degree arc calcium. But I don't think that's, there are many, many cases where, especially with minimal debulking, which is what I think you'd be doing here, that you could achieve that with a laser.
All right, we're going to pull this back a little more.
I think what we're going to use as far as atherectomy concerned, that's something that remains to be seen after you do a recanalization, a couple injections, see what's going on. Then you're in the position to decide what debulking device you want to use. I think laser would have been a great idea here because it's less traumatic and easier to use. And so this all remains to be seen after you really go across that and doing just balloon dilatation itself might be totally sufficient.
This is, in my opinion, one of the toughest areas of the body to treat, though, the P3 segment of the popliteal artery going into the infrapopliteal vessels. And the reason it's such a problem is there's profound size mismatch. There's often calcium. And any balloon that's the right size for the infrapopliteal vessel is too small for the popliteal, and vice versa. Any balloon big enough for the popliteal is too big for the infrapopliteal segment. And therein lies some of the problem in treating this area. This is a particularly tough area. Jack did a masterful job of crossing this. It's going to be very interesting to see after he does the initial treatment. I would not be surprised if he then sees a nub of an AT to go after and also the perineal. And it's become my standard to actually go after more than one of these vessels. It's been my experience that in particular with intact choke vessels in the foot, that if you get multiple vessels open, you have better long-term outcomes. What happens is they heal ultimately from the angiosome-related vessel, but typically if you don't need quite the same flow to stop something from ulcerating as you do to heal an ulcer. And so I think the more vessels you can get, the better if you can get them.
I would agree. I mean, global perfusion to the foot is the goal. And this patient has a pretty decent collateral network already in place. So if you can reinstate one or two more vessels, certainly if the outflow is in favor in those vessels too, the patency on that work is going to be improved. And we're not expecting these to stay open forever, but enough to heal the wound is the goal here.
I think this is also where Dr. Jenkins earlier talked on wound perfusion evaluation with TCPO2 or laser Doppler or some of the newer technologies will also guide you. If you have such a great arch and now you go ahead and do a TCPO2 after and have wonderful tissue perfusion, this may be all that's needed and you may avoid a repeat procedure. So, in some ways it may be worthwhile, especially in this case, if you have a nice flow in the arch, to stop and then wait and see how the patient does after you do some evaluation.
One other remark I would like to make, and one vessel a day, I think that would be good enough. In other words, if you have to recanalize another vessel, you don't have to do them all in one setting. You can recanalize and get a good result with PT and then bring the patient back a couple days later and take a look at it first of all to see how your PT is functioning. Then if you have to go after another vessel, do it in the second setting.
It's a great point, particularly if there's an issue with renal function. Yes? He's advanced the wire.
What's that?
Tom was asking a question about what you were doing with the wire, that you'd advanced it. I think you were advancing it to put it into the catheter above to reverse the wire. Is that right, to where you'd have the soft end of the wire downstream to treat the patient?
Yeah, that was our plan. I went ahead and just ran the wire all the way up and out the original support catheter from above. And then once we got a hold of the wire, we've been trying to get our original integrated wire all the way down, integrated support catheter down across the lesion. You can see right now we're kind of running into resistance, so we may have to change our plan and take you up on the laser offer, because it won't cross there. Now we could move up to a better one, I guess.
Yeah. No, he crossed the lesion with the wire, and then he followed with the catheter, and then he put the wire into the catheter above, and then he changed wire, I think, to a Viper wire. I think
we haven't changed wires yet.
Yes, he
so
changed.
We're just body flossing right now.
Yeah. So one of the advantages, and he's bringing this up, is sometimes if you have a wire sticking out at the leg, sticking out of the foot, and one up above, if you grab each end of them, you could drive a Mack truck across that.
Why don't we just warm
You've
up
got
the
a real
laser,
rail,
just in case, 'cause I don't
and you
think
can get whatever you want to cross, and that's very helpful in certain cases.
Do we have an 018 CXI catheter? Let's try that. So this is a Trailblazer. We're gonna try to move up to a CXI, see if we can get across this. If we can cross it, I would like to drill it. If we can't, we'll get the laser warmed up and do that. We have two good options, I think.
I agree. The CXI system I use a lot. I like the tunneled 4 French with the 2.6, and I think if you can track the 2.6 down a wire, usually you can get pretty much anything through after that. So
can you get
establishing
a 90?
that pathway is helpful.
Yeah, I've been really impressed with where
would help.
CXI will go. It's an impressive catheter.
Yeah, perfect.
So the Viper wire is in, though right now it's 14 thousandths. And so I guess the other thing you could do if this doesn't easily cross would be to start off with something like a center mark or coronary balloon. That would typically go across as well.
Right. Yeah, we could do that. And we definitely know it's kind of a short spot down there where it's really harder, and that's what worries me a little bit about that it might be a little more calcified than we realize.
But Jack, you've already taken what's a very tough case and really made tremendous headway. I think you've pointed out many of the advantages of the pedal approach here. You notice that maze of collaterals he saw from above. There was no clear path, none of these other things. You saw that when he injected from below, there was a huge segment of hibernating vessel. This is the rule, not the exception. It's a very important thing. And then we have these great pedal vessels. I tell people all the time that as a fellow, when I was at Harvard, I went to one of the grand rounds, the joint grand rounds, and one of the comments I'll never forget was a comment from Dr. Pompaselli, the vascular surgeon, in which he said more legs have been lost due to the myth of microcirculation in diabetes than any other reason, because often there are vessel targets at the foot. Well, I think the second quote would be, second most legs have been lost from not understanding microcirculation. So I think they both are important. I think that many of these people do have microcirculatory problems.
Cheese out. Sorry
but he
about
is
that.
right. Often, even when we don't see vessels, they are present.
Could
And I think we have to keep both of those in mind.
instead? Sorry about that.
So, Craig, you agree that functional microcirculation is clinically significant? And how does the vascular surgeon or the interventional cardiologist and radiologist look at that aspect of it?
So, Jack, if it's okay with you...
Are there markers to tell you that before?
Actually, ultrasound's gotten better. Some of the MR's gotten better. And so we have gotten better ways to tell this. But in 1980, when he made that statement, we really couldn't tell. To be honest with you, you would do angiography from above, and you could not tell. And so people were just cutting those legs off, thinking there were no targets. He started doing cut down, and he realized 80% of the time there were viable targets, and he saved a lot of legs. And so I think it was really an enlightening comment that he made at the time, and it stuck with me to this day. So obviously it was an important comment. Jack, if it's okay with you, while you're doing this turnaround, 'cause it's going to take a little round, would you mind if we do one lecture and come back to you?
Oh, that'd be perfect. Well, go ahead.
Okay, great. So I'm going to invite Dr. Prakash Krishnan, who also puts on a great meeting in New York each year, to talk to us about how important is patency and how do you determine the need for repeat vascularization. PK?
Thanks so much, Craig. I'd like to thank Dr. Jaafer, Golzar, as well as Dr. Murtajme, and all the directors of the course for having me here, and hopefully I can add a little bit to the course. So this is a very important topic that Dr. Golzar has assigned me, and it was how important is patency and how do you determine the need for revascularization? So I thought long and hard about it and thought about how I should present it, so I'm just going to go ahead and take a wing at it here. So these are my disclosures. So generally, if we're talking about patency for CLI, and since we're in a CLI session, you want to salvage the limb. So in order to salvage the limb, there's multifaceted approach. You need to offload the limb and also have good wound care. You need to have medical therapy, limb salvage, and straight line flow are all part and parcel of a good limb salvage effort. So in CLI intervention, the final goal, the reason is limb salvage, the final goal is to preserve a functional limb. So is patency essential? Or is optimal revascularization followed by wound assessment and a multidisciplinary wound care approach, is that what's really important? So what are the factors we need to consider? Well, first and foremost, the number of vessels, vascular vessels involved, the plantar arch patency as we've been talking about, the amount of tissue destruction, the presence of infection, the need of debridement or skin graft, the availability of conduit if you're looking at a bypass, the comorbid conditions of the patients, and especially the nutritional status. So guess what? The aha moment, it is more than just patency, but patency is important, and I'm going to go over that. So let me go over some of the data that we have, angioplasty and CLI, multiple other modalities, just to talk a little bit about how we've done with limb salvage. So this is an old paper, I mean, this was presented many years ago, which clearly showed in 235 patients, there was 91% of limb salvage was achieved with just angioplasty. And then this was also shown by Dr. Graziani and his group in Italy with almost 1,000 patients with a 5-year limb salvage rate around 88% with just angioplasty alone. And this was also reproduced by Kudo and An, Musa and Rees, and all showing limb salvage rates around 97, 89, and 97% with well over 1,000 patients followed for about 5 years. So what about, now, so angioplasty works in terms of limb salvage. So what about cutting balloon angioplasty? If you look at Ansel's group showed that they achieved an 89.5% limb salvage rate with cutting balloon angioplasty. And subintimal angioplasty also works in the tibial vessels with a 1-year limb salvage rate around 85%. If you want to use cryoplasty, Dr. Laird showed in his study that around in 365 days there was about an 85% limb salvage rate as well. And if you talk about the Lacey trial in terms of limb salvage rates, if you're not going to use balloon and you're going to go ahead and use a laser, you had a 6-month limb salvage rate around 93%. Bare metal stents also work in terms of limb salvage rates with the clinical success with healing and limb salvage rates around 96%, and this was presented in 2004 and published. So is patency important? Well, the question really should be, can we improve our wound closure rates? Because there's a big difference between limb salvage and wound closure. And number two, can patency help prevent repeat ulceration and complete wound closure? So therefore, the question is patency going to help us to achieve these two goals? So we learned from Definitive LE, which was a multi-center registry with atherectomy, that the greater the duration of the patency, the better the limb salvage rate. So wound heals better at 12 months at 72% versus 6 months at 61% and at 3 months at 52%. So this leads us to where we are now. We're talking a little bit about DES and DEB. So what about drug-eluting stents and what have we learned in tibial interventions? Well, we know in the 12-month follow-up of drug-eluting stent and multiple randomized trials, Yukon, BTK, Destiny, and Achilles, that clearly the TLR rates were reduced. But however, I want you to focus very carefully because the limb salvage rates were unchanged. If you look at the TLR rates in the Yukon BTK, for instance, it was 9.7 versus 17.5, but the limb salvage rate was 98% and 96%. So patency and limb salvage may not exactly correlate. However, if you look at the mean lesion lengths, 30 and 31, these were relatively short lesions in this particular trial. Again, this is an example showing you of all the three things showing that you can incur patency by using drug-eluting stents. So you can definitely improve your patency versus standard trial. If you look at the major adverse event and limb salvage at 2-year follow-up in CLI patients in the Yukon trial, if you look at the sirolimus arm, again, small number of patients, the major and minor amputation was 5.3% versus 22.6%. And the limb salvage rates, as you can see below, were pretty similar, 97.4 to 87, although they were significant. So DEB and tibial trials, but the clinical reality in CLI is that you have diffuse long lesions. So drug-eluting stents may not be the way to go in terms of clinical patency, and drug-eluting balloons may be the way to go because of the long, diffuse nature of these lesions. So the only randomized trial to assess this was presented in Link in 2013, and thank Dr. Zeller for the slide. And this looked at CLI patients and diabetic and 150 tibial lesions randomized to DEB versus standard PTA in 75 lesions. And this was a single center trial, and these included CLI and diabetic patients. What you see here immediately is that the lesion lengths treated are different, 12.8 and 13, so much longer, more real-world type lesions are being treated. Again, you see that the TLR rates are low, but here you can see there was a 59% reduction in TLR and a 28% wound healing increase in the wound healing rate, both of which were statistically significant. So bottom line, intervention works, but is this enough? What else do we need to do? Well, the follow-up, the key to this is beyond the intervention that you're going to do, you need to do surveillance and you need to do wound care, okay? So currently now, what tools do we have? Well, everybody will tell you, okay, you're a great interventionalist, you open the wound, and most cardiologists in general tend to stop there. But we need to do more. So with the ABI, TBIs is what we've been doing for a long time, and this is really a class 1 indication by our guidelines. But however, is this enough? Well, this nice study presented out of Cleveland Clinic by Mehdi's group clearly showed that the ABI does not reflect infragenicular vessel runoff. So just by having an ABI does not predict whether you have 1, 2, or 3 vessel runoff. And if you do the TBI as recommended by our guidelines, it's also not enough. So where do we go from here? We need to do more, kind of what we talked here. Once you've established flow down into the foot, you want to go ahead and look at multiple other modalities that are available. TCPO2 was elegantly talked about earlier, so I won't spend too much time on it, but generally it measures oxygen tension 1 to 2 millimeters deep in the skin from local capillary perfusion. It's useful for wound healing prediction and can be used to assess the response to hyperbaric oxygen. Again, some guidelines just to remember that TCPO2 less than 30 is generally critical limb ischemia, greater than 70 is normal, and the low values can be confounding because it can be due to a lot of confounding factors such as edema, inflammation, things that people with limb salvage would have. Skin perfusion pressure was also talked about by her, and clearly it uses the laser Doppler to determine the return of flow or reactive hyperemia. And again, just to skip through, you can see here that greater than 50 or greater is normal skin perfusion, less than 30 pretty much indicates that your wound is not going to heal. So what are the advantages of skin perfusion pressure versus TCPO2? Skin perfusion pressure's advantages are it's not affected by vessel calcification, callousness, or thickened skin or edema. It can be used on plantar foot and digits. It's generally more sensitive in its ability to predict wound healing and relative to TCPO2. Its disadvantages are if you're following the wound on a patient who's undergoing hyperbaric oxygen, it's not exactly the best way to do that. And again, it may be painful because of the blood pressure cuffs. Newer technologies, we talked a little bit about this, the intraoperative fluorescence angiography. Dr. Jenkins just mentioned slightly that it was very, very expensive, but it's extremely useful. And this photo is given to me by Mehdi from Cleveland Clinic, clearly shows that while we as interventional cardiologists are working in the, or interventionalists are working in the vascular angiography suite, we can actually see whether our work is perfusing the wound. And this may actually be the future to really see where we're going, and not so much, anatomic flow or angiosomes. So wound perfusion and clinical variables, for physiologic and anatomic definition, you can do an ABI, PVR, and TBI. I've clearly gone over what are the limitations of both. TCPO2 is another option. Laser skin perfusion is another option. Ultrasound and also angiographic collateral in the flow in the foot will also help. But the bottom line is we need to create wound care teams. We need to have an interdisciplinary team, patient, family, practitioner, nurse, wound specialist, dietitian, and the pharmacist have to come up with a care plan. So that without the multidisciplinary approach, we fail to assess the patient and the wound. A lot of time as interventionists, we just treat the artery, we don't look at the nutritional status, we don't debride the wound, and we don't treat the infection. So don't blindly believe non-invasive testing either. Look at the patient clinically and decide whether you need to re-intervene. You don't have that holy grail right now to tell you, hey, guess what, doctor, you need to go back and open this wound. The wound is down. You need to follow the patient as well as the team and appropriately use further intervention to salvage the limb. So remember, optimal intervention is essential. Okay, patency plays an important role, as you've seen by the early DEB studies are showing. However, we've achieved limb salvage without sustained patency in the past. The reason for that, the failure to salvage the limb may be a lot more than restenosis. Thank you.
PK, thank you for that great lecture. Our next speaker is a true luminary in the field of podiatry and someone I've worked with many, many years, Dr. Larry Harkless. He's going to speak to us on post-revascularization for toe gangrene, proceed with toe amputation, or wait for auto amputation. Dr. Harkless?
Thanks, Craig. That was an outstanding talk that you just gave. So I didn't finish my talk the last time, so I'm going to take a minute to do that. I had one slide I wanted to show, and I think it's the most important slide of this program. The diabetic foot is common, it's complex, and it's costly. Why? Because of heterogeneity. And these are about 12 things here that happens to patients, and sometimes we forget. So as I mentioned earlier, that Arturo Guandig had the book called The Checklist Manifesto. When I make lists and check the list, I tend not to miss things. And so it is a multidisciplinary approach, and I think you have to think about all of that when we look at the patients. The history and physical informs a system of care, and we know that if we have a good system, we can get good results. But the interesting thing is that if we have a system, most of the time it's not followed. It's not bad people, it's just the bad systems. So the system as related to diabetic risk and wound system have been validated. We came up with the University of Texas Wound and Risk System that has international guidelines, and I left University of Texas in 2007. I became a dean, and I founded a new college of podiatric medicine at Western University. So I graduated my first class in May of 13, and I brought all the students back in December of that year to Arrowhead, the county hospital in San Bernardino County, to see what do you want them to know and how do I know they learn. And what I realized was that they weren't using what I taught them. And it was amazing. They had been all over the country, visiting all the various residences in our profession. And so what you will find out is that the system is really not used. So let's get back to my talk, toe amputation versus auto amputation. Well, I don't really know what the right answer is, and we don't really have any evidence to guide that. So I think we have to use common sense. When there's not evidence, you have to use logic, and I would say all good minds think alike. So what impacts surgical decisions? The previous speaker talked about most of this: infection, tissue loss, circulation, bone involvement, rehabilitation issues, patient's choice, surgeon's experience, and really the problem wound. And I think that that's what he was alluding to in most of his conversation when he said, I got the blood flow there, but it still didn't heal. And that's the elephant in the room, as I would say. And I would tell you that you need to go back to Michael Brownlee's work from Einstein that talked about the pathobiology of type 2 complications. And that's kind of how I think about the foot. I don't have a theranostic to tell you what's missing in the wound, but if I believe what's happening is inflammation at the cellular level and they've already developed the complications, that's basically how I think. And so if you go back to the protein kinase C, when that's abnormal, nitric oxide is decreased and everything else is upregulated, that's deleterious to the wound healing cascade. And so I don't have to be thinking about that after I've done the bypass and all of that. I thought about that when I saw the patient in the emergency room and when you consulted me, and I write that in the chart. So over many years of paying attention, I think I'm pretty good. But you still can't trust me. You still have to do the study, the data, and get the evidence over time so that we know. So there's still a lot of work going on in that area to give us more information in that regard. The decisions are driven by one factor in isolation or a combo of factors. For the same lesion after discussion and education, patient's choice can lead to a conservative, local surgery or BKA. And we were talking about more or less a toe. So each treatment could very well be the best choice as we think about that. And I've had residents, sometime I wanted to do something, and they come back and say, Dr. Harkless, did you ask Ms. Sanchez or Ms. Flores what she wanted? And it's amazing sometimes when you step back and look at that and think about all the psychosocial aspects of the patient and what they really, really need in the armamentarium and what we have to offer them as it relates to limb salvage versus he was talking about the patency of the blood vessel and healing. So functionality is important if you're talking about a toe. So I think you should try to save the hallux in the second toe as much as possible, because once you take the hallux off, we published a paper in Diabetes Care looking at the natural history of a great toe amputation. And within 6 months, you start to develop more callus under the second, and you start to get more pressure under the second, and you can have a reulceration. Even with the best of shoes and offloading modalities, that's still difficult. If I can save at least half of the second toe or part of it, I can prevent the great toe from going into a hallux valgus or a crooked position. So that's important if I'm thinking about that in a fairly young patient that is fairly compliant and trying to rehabilitate them. So the third, fourth, and fifth toes are really not as critical. So an endovascular procedure, I would say that you need to do the procedure sooner rather than later. Why? Because there's a high rate of stenosis, and I think that's been talked about here as it relates to the endovascular interventions. Open bypass procedure, it's important to assess whether it's infected or a problem wound. And it's important to determine the etiology. And then you need to debride the wound. That was talked about significantly by the previous speaker. And sometimes you have to go back for multiple debridements. But I normally can predict that if the nitric oxide is depleted, if the patient has sexual dysfunction, I always put those patients in a different category as I follow them. You can still get the patency there, but I still think that you have a better idea about how often you may need to go back and debride. And with the negative pressure therapy and all the other modalities, I think we have a lot more in our toolbox to utilize to get the patients to an optimal state so that you can get actually wound closure and long-term follow-up. And Dr. Jenkins talked about the importance of offloading and putting the patient in appropriate shoes. We still do not have good data on shoes and what works. There was one paper in JAMA in 2002 by Gail Reiber and that group from Seattle, and it basically said that that shoes really didn't work in that particular prospective study. And I wrote the diabetic shoe demonstration project with Marv Levin, who wrote the first diabetic foot book from WashU, and that was the first program that was actually approved by Medicare for prevention, where patients can get shoes, a pair of shoes and 2 or 3 inlays on an annual basis for prevention. So on a stable wound, I think we can wait and maintain optimal perfusion. And again, I look at all the multifactorial risk factors and decide that. That way you can get the maximum amount of flow, and then you can go back several days later or a week later to perform the appropriate amputation. So when we talked about the wound bed preparation and the wound healing part, this is a schematic here looking at all the different abnormalities that can go awry. So you have necrotic tissue, you have edema, you have infection, again, the biofilms, necrotic tissue, the matrix can be corrupt with MLPs, etc., and you can have a problem in the cellular burden. But this is all those inflammatory changes that's actually going on at the cellular level. And so if you ask the questions, are all chronic wounds the same? I would say no, they're all in evolution. And so you have to pick and mix and decide, really what's going on and what's missing based on that pathobiology that I was talking about earlier. So also you have to think about the complications of your amputation in terms of what you do, what will you create. So if you take the hallux off, again, we talked about you develop a hammer toe in the lesser toes. If you take the second toe off, we mentioned that you develop hallux valgus. If you take other toes off or metatarsal head, it's predictable that you'll get a transfer lesion to the adjacent metatarsals. I believe that the biggest culprit and why that happens is limited joint mobility. So I always check the motion from the hips to the knee, the ankle, subtalar joint, lesser MTP joints, PIP and DIP joints. And I would say from years of experience that the most common reason for recurrence is really limited joint mobility. Most patients will be very stiff, and they'll have normal anatomical variations in the lower extremity, meaning that they'll be bow-legged. I'm from Texas, and although Craig is from Louisiana, from riding horses, I'm getting more heel pain, and I have callus on my heels, and I hope I don't get diabetes, but I have a strong family history, and if I got genetically tested, I bet you I have the gene for it. But Craig, thank God I'm living in California because I eat fresh at night. I got a farm in my yard. You don't have to have talent to grow anything there. It just kind of grows. Transmetatarsal, you can get stump ulceration because if you have a cavus foot and if it's not balanced right, if it's rigid, you can still get pressure there. And you can also have equinus. So in list ranks and show parts, the most common reason you can get varus and equinus. So you need to evaluate that pre-op, looking at that in the motion. So you may need to do TALs, etc. Symes amputations can have heel problems. You can have bursitis and ulceration from the BKs. So all partial foot amputations, risk complications are new ulcerations. So if you say the foot is likely to re-ulcerate if you don't really understand the mechanics and the function of the foot. So after spending 30 years at the University of Texas, and now I've been in California 7, I've opened up 2 county hospitals, San Bernardino and Riverside, that didn't have podiatrists. And what I realized is that we spend more time studying the foot and understanding the function of it, and more importantly, we have passion and love what we do. And so you have to have that team approach. That is so important. I was healing wounds that had been there for about a year or two at San Bernardino County, and I got a call by the head of the wound clinic, and he said, Dr. Harkness, the head of ambulatory care is upset because you've been putting on all these casts. And so I said, well, what do you mean? He said, well, I have to go to a meeting. Can you come and help me? I said, I'll tell you what. If you can get me a computer hookup in about 5 minutes, I'll show them all the data, and they're going to do either one or two things. They're going to either us one cast tech, or they're going to hire us 2. And so guess what happened? We got 2 cast techs hired. The next week, I went over and gave the report with the data. So I think that probably county hospitals are probably third world countries in most cities if you don't have a really good team and a really good podiatrist. I'm not saying it has to be a podiatrist. It could be an orthopedic surgeon or someone that really has passion to the foot that really want to change the problem. And this is my last slide. I got 9 seconds. Infection here. Because it was infected, we felt it needed to be debrided. Didn't have a dorsalis pedis pulse. So this is after that. Because the patient was sick, it took about a week to get the patient through the workup, to get the vascular workup, and so she ended up having a bypass. You can see here that she didn't have any anterior flow. And if you don't have a pulse, and if there's a lesion, you can predict that where the lesion is just by the exam of what I mentioned today. But she had a bypass, so we ended up waiting about a week and a half before we came back to make sure that the bypass was functioning fine to end up with a TMA, and she actually healed this particular thing at that point. Thank you.
Dr. Harkless, as always, a great talk. Can't emphasize for the audience enough the need to have a team. And when we started Horizons, the meeting, that was our first focus. You have to put together a team because it's not just about getting flow. Jack, we see you again. Can you tell us where you are at this point in the procedure and what you've done?
We got across with CXI from above, so we just flipped our wire around and decided to use a laser. I let them vote in the lab here, and they said, look, you made us roll it in here, so we have to use it. So we did. We did 2 runs with a 0.9 laser. We did 60-40, then 80-80. And here's what our picture looks like. Hold on a second.
Did you have much resistance to crossing?
So we got a little lumen there. What's that?
Yeah, did you have much resistance to crossing with this laser or not?
Yeah, we did at that same spot, and but it went through at 60-40, and it went through even easier at the next time on the 80-80. So we decided to see if we could get a long vascutract balloon down there and see if we could balloon this whole long segment.
Craig, this is PK. I was just wondering whether you could talk a little bit about how you changed the fluency and the rate of the laser and what's your algorithm?
Yeah, we have 2 things we adjust on a laser. Laser gives 125 nanosecond bursts of energy, up to 80 of those per second, which means it's actually off 99% of the time and on only 1% even at the highest frequency setting. And then we have fluencies. Fluencies range all the way down all the way up to, on the smallest laser, 80. Now, the higher the fluence is how much energy density, or it's measured in millijoules per millimeter square. It's how much energy we're delivering at each point along the surface area of that. Higher fluence gives us a bigger channel. It also has more ablative capabilities on thrombus. Higher frequencies give us better ability to penetrate calcium.
All right,
and so I would adjust those accordingly. So did the VascuTrack cross pretty easily, Jack?
What's that?
Did the VascuTrack cross pretty easily?
Yeah, it went down fairly easily.
Good. So for those of you who've never used this, this is a balloon it's a rapid exchange. It has a 1 centimeter distal port. It has an externally affixed wire the length of the balloon. So I presume this to be a 30 centimeter long VascuTrack. There is therefore a 30 centimeter long wire affixed the length between the two markers. And then it uses your wire as a second wire of focal force. And at those two sites, it applies roughly 300 times the pressure of just the simple hoop stress of the balloon. The idea being that you will get a little easier dilation of the lesion. What size did you choose here, Jack?
Yeah, right now. We got a 30200 is what we used. So, and we only went up to about 4 atmospheres there, and everything opened up, which it should. So we're going to come back and get the tibial-perineal as well.
Jack, this PK, how long do you typically leave these balloons up?
There. Usually 2 minutes. So we're going to go up here and see how this responds. Can you see? Yeah, you can see that.
Amir, do you do anything different in
Pretty
terms of the balloon time?
Oh, it depends on the artery. The harder the artery, the longer the inflation. I go anywhere from 2 to 5 minutes.
So how do you gauge the hardness of the artery? You're saying the heart of the artery, you said? So how do you know? That's my question, whether it's the, that's what...
Well, sometimes I leave it up to 5 minutes, and yeah.
So do you look at the calcium, or...?
Well, if it is, when you recanalize the artery, you get the feeling that
so just the feel.
Good or bad this artery is going to be.
Gotcha.
Yeah. So you put your judgment on several different things. Gotcha. One is the way you recanalize the artery. Sure. If it gives you a really hard time, then you need a little extra time to dilate that.
Yeah, like in this case, he had to go to a very low-profile catheter to cross. That's a pretty good indication it's hard. You saw calcium. That's a pretty good indication. All of those things, I think, play a role.
And calcium is different in our arteries. If the arterial wall is calcified, it's not like you have calcification intraluminally. Yes. As a matter of fact, some of the arteries that are have a calcified walls, they get dilated a lot better, and they stay open much better,
Sort of an
once you have
stent.
an intraluminal calcification, then you're talking about totally different entity.
Do you remember that? Grunsik used to call that auto-stenting in the past. That's what he called it. It held it up.
Beautiful result.
Oh, very nice.
The reason I asked that question, Amir, was that, as you know, recoil is the major problem with the tibial vessels. So I was just curious to the panel as to, you think a prolonged balloon inflation would reduce the rate of recoil, or do you think it's the pressure of the balloon that you go up that has the effect on the recoil, or a combination of both?
I think it's a combination of both. And I don't know, maybe even have a sort of psychological effect on the operator. You think that you lift the balloon in, you're doing a greater job.
Depends what time of day, how long you leave the balloon up.
I think from the physics explanation of that, though, both are important, but for different reasons. Longer inflations affect plasticity. Just like if we took a toothpick and bent it very slowly, a wet toothpick, it would bend, whereas if we bent it very fast, it would probably break. That's the long inflation. But the very rapid inflation is more apt to give us dissections, which is another reason. So I think you're trying to affect strain, but you're also trying to affect plasticity. And the way that we get to those is by slow inflation and by prolonged inflation.
I agree. In my practice, I explain the silly putty effect. If you pull silly putty quickly, it tears. If you pull it slowly, it strings out. So my balloon inflations are long and low atmospheric pressure, so you don't create barotrauma. You know, the other issue here is there's a focal spot where he traversed, and that was the challenging spot. Most of this is probably hybridating lumen, so it doesn't need, you know, necessarily in those locations, but at that focal spot, I focus on that, and once the
tight
balloon
is
reaches
it,
max inflation, I
banded?
stop inflating the balloon. That's the pressure that I've expanded it enough to get
Yeah.
that spot.
You know, Jack, it was very interesting with that first shot you
500.
took. The distal posterior tibial is occluded, we see right now, but you could see the anterior tibial lighting now much higher up. You could also see the perineal, and is often the case when you have a concomitant popliteal occlusion with these other vessels. Once you open that popliteal segment, you often see these other vessels much better.
So what we had removed our sheath out of the ankle there. Not our sheath, but our catheter, because we wanted to get it out of the way. And so it may be a little spasm, maybe we have a lesion
Sure.
kind of right near where we had to stick that we still need to treat. So we're going to try to get our wire past all this junk and try to balloon more distal without making our bleeding worse. It's not bleeding now, but so we'll see if it'll go any further. It's trying to.
What I
We're
usually
just
try to
backing
do
up.
is just a matter of practice, is I usually try to get my wire beyond early on, leaving that catheter in, and then during my inflation, I pull the catheter. I found that usually gives us rapid sealing of the
Well,
pedal
to
approach.
me, that is only for access.
Okay.
Once my wire is
It comes
retrieved
out.
from above,
How's it look?
I pull that
Yep, me as
wire
well.
right away.
No bleeding?
I don't sit
Yeah,
on
cool.
that and
It's
keep
not
that catheter.
Yeah, there's not,
I
it's
agree.
not like a pressure thing. Yeah,
Because
cool.
the job is done. You know, you just
You can take
want
your
to
hand off.
access. Then everything else I do is going to be done from
Stay there.
above.
So now you're beyond this
So
area
can
and
we-
dilating beyond. Great. See, one of the things I really like about what Cook has done with this little 2.9 French sheath that lets us not be occlusive is A, it lets us not be occlusive, but B, it allows us to
We might
continue
need another
administering
balloon.
medicines like vasodilators, like anti-clot drugs, all of these things. The two big
Like a
enemies of the
3040
transpedal approach
somebody,
are spasm and
3040,
clot. The third big enemy is dissection, but you get that if you go up with a wire and you're not careful. But I don't think you're more, I think you're less apt to get dissections. But if you get them, that's the third enemy. But spasm and clot. And so in these cases, I tend to repetitively give nitroglycerin. I tend to repetitively give the anticoagulant that I'm giving into that pedal vessel early on until I'm ready to move on. Great job so far on this case, though, Jack. Really, this is a very tough case to take on live, a very tough case to take on, period. But you've crossed masterfully. You've got this other part going beautifully. I'm going to be very curious to see this final result.
Sure. We're going to, thank you. We're going to take a picture here. We need to balloon a little further, but this won't go. So we're going to get a just a 304, a 3040 balloon, 018, a normal one, and see if we can get down there. Let's see what it looks like. Though we did give about 500 of nitro.
Cool. No, the sheath he's taken out. I'm pretty sure. Jack, you took the sheath out, right?
Yeah.
Yeah. So
Yeah,
now we
that
have
looks
flow.
pretty good. We just need to balloon that spot there.
Yeah. Or are you going to stay the same size, or are you going to drop your size a bit?
I was going to use another 3.0 at low atmospheres. The other question is, might be worth trying to get the laser back down there and treat a little more of this first. So I think we'll do that first.
Yeah, you've already
Let's,
ballooned it. I would probably just balloon it personally, but
Yeah.
you know, at this point down here,
Uh-huh.
that area was patent before. It wasn't totally occluded because you were able to stick it,
Well,
right?
you can.
I think
Well, let
this
me
is
show you what it
partially,
looked like.
partially a spasm too,
I agree with that.
because this segment
Yeah,
wasn't like this
I agree with
when
that.
original angio.
There was some disease, though,
here,
and Jack
take a look at
alluded to it. Remember he said he had to crunch through the lesion?
Right
I-
there.
Yeah, I think if I were you, I would drop my balloon size here a little bit and just do a long inflation. I think you'll get a good result. I think there is some spasm, but your initial description of getting into it and feeling all the calcium and all of that, I think it might be a wise idea. Just a low pressure inflation.
Yeah, I did.
All right, we'll do that.
Jack, you did a great
I don't know
job.
if you see that picture there. Thank you.
You even impressed me.
Wow, gosh.
Let's record that statement for all time.
Yeah, this is being taped, right?
Well, I think right now we're going to come back to you, Jack, because I see they're putting up my title. I don't know how I did this, but so if you don't mind, we're going to go on to the debate, and then we're going to come back to you. But one of my big rules in life is never debate Amir Mutajameh. And here I am doing just that. And it's a tough debate, but we'll see where we get with this. So I've got to thank Jaafer for giving me an absolutely impossible task. And I've been given the topic that angiosome-directed therapy is absolutely necessary to heal an ulcer. You've already heard me say earlier, sometimes a single vessel is all we need. So I don't absolutely 100% believe that, but I sort of believe it. And we're going to get to why I sort of believe it. Now, I apologize for this, but apparently when they added this on the bottom, it didn't come out quite right. But if we look at the pedal vessels, what we see is that they're typically great collateral, let's just say collateral vessels. And this was changed after I changed the slide a little bit earlier. But there is normally great connections between these vessels. And that's why, for so many years, surgeons bypassed the best distal vessel and achieved limb salvage. But Taylor, who was a plastic surgeon, published in 1987 the concept of angiosomes. And these are composite anatomic vascular territories of skin and underlying muscles, tendons, nerves, and bones based on segmental distributing arteries. And this came up to determine who would heal these flaps. Well, that's not good enough for me. I've got to create my own definitions to understand things. So I describe this as a three-dimensional block of tissue supplied by a specific artery. Although there's typically collateral blood flow from neighboring angiosomes, and this blood flow gets there via what are called choke vessels. In certain disease states, particularly diabetes and chronic kidney disease, it may be inadequate for tissue healing. We've all seen cases like this. There must ultimately be flow to the area of ulcer or wound healing, either by the specific artery that typically supplies that angiosome or via these choke vessels. So in my opinion, angiosome-directed therapy is crucial. We have to get blood to that area, but it doesn't always have to be via that angiosome vessel because often there are great collaterals. Now, angiosomes were defined not by vascular surgeons, not by interventionists, but by plastic surgeons. They wanted to determine if a skin flap would heal. Now, there are 6 basic angiosomes which were described in the foot by Edam. 3 of these arise from the posterior tibial, 1 from the anterior tibial, and 2 from the perineal artery. And these are they. If we look at the foot, we can see on the left the distribution of the typical anterior tibial, the dorsum of the foot and the lower leg. If we look at the posterior tibial, we have the medial plantar, lateral plantar, and calcaneal angiosomes. And if we look at the perineal, we have the calcaneal branches and this other lateral branch. Now, this just shows the posterior tibial and the lesions one would expect. The medial calcaneal angiosome and a heel ulcer, the medial plantar angiosome, and an ulcer involving the great toe and the medial side of the foot, and the lateral plantar angiosome affecting the little toe. But it is also important to understand that nothing in medicine should we always use the word always. And that was one of my problems with accepting this debate. because it said in my title, always. I think always is something that we should never say in medicine. I don't like the term. Because even with angiosome-directed therapy, angiosomes are not always the same. Our anatomy is different. How much so? Well, you can see that these vessels may branch in many different ways. Sometimes we don't even have an anterior tibial or posterior tibial per se. It may arise, there may be a dominant perineal which comes down and fills these other vessels. But at least in concept, we have to get blood to the ischemic area. And if we've got to do that, or else we're simply not going to have healing. So this whole concept was determined to determine which artery should be fixed based on the location of the non-healing wound, taking into account the usual circumstance of what supplies what. Hopefully, direct revascularization would be optimal and time-saving and cost-saving. But we have to keep in mind there are anatomical variations, and classically described angiosomes do not apply in all patients. For instance, one of those cases I showed you, the perineal was the only vessel going, and it totally supplies the entire foot. In that case, it gives rise to all 7 of the angiosomes. Now, what data do we have to support that angiosome-directed therapy matters? Well, from the interventional perspective, perhaps Dr. Aida in Japan has published more on this than anyone. He created the so-called JBEAT registry, which stood for Japanese Below-the-Knee Artery Treatment Registry. There were 1,068 limbs and 900 consecutive CLI patients who underwent endovascular therapy between April of 2004 and October of 2010. And you can see that 1, 2, and 4-year limb salvage was much better in the people in whom he achieved direct vessel angiosome perfusion. So if it was the anterior tibial angiosome, if he got the anterior tibial open, it did better than if he simply got a good posterior tibial to the foot, and vice versa. You can see that in this study of endovascular therapy, it made a difference. We also see that skin perfusion pressure after endovascular therapy was much better in that angiosome in those cases where the patient had the vessel that typically supplies that angiosome reperfused. In addition, we see that freedom from amputation was substantially better with direct perfusion of the angiosome. And this was not related whatsoever to the number of runoff vessels. So very important. This whole concept of if you feel a pulse in the foot, it means the foot can't be in jeopardy is wrong, wrong, wrong. And I'm going to show you another case to show you that at the end of this. Now, in the surgical literature, Dr. Neville also looked at this, and he determined whether it mattered which vessel you bypassed. Did you go to the best foot vessel, or do you go to the angiosome-related vessel? And they did a study looking at 60 consecutive wounds. There were 52 wounds. 8 were excluded due to incomplete follow-up. There were 9 premature deaths, so that left 43 wounds. 22 of those had been directly revascularized going to the angiosome vessel, 21 indirectly. And we can see that of the 22 that were directly revascularized, 20 healed, and of the 21 that were indirectly revascularized surgically, only 13 of those healed. I'm not advancing here. Can you help me advance from the back? This is not advanced. Okay. And you can see the graphs that were used, high mortality. So if we look at this, we see that in the direct revascularization group, 91% of them had complete healing, whereas in the indirect revascularization group, only 62% had it. So I think there is some data that we have to get to that spot. And we can see direct versus indirect freedom from major amputation, highly statistically significant. Freedom from major adverse limb event, highly statistically significant. Amputation-free survival, highly statistically significant in this study, despite relatively small numbers of patients. So what do I think about angiosome-directed therapy? I think when there's intact collateral flow, lone vessel to the foot may be perfectly adequate for wound healing. But when there are impaired choke vessels, and this is far more common than we initially thought, direct revascularization of the angiosome may be necessary for wound healing. One such case, this is courtesy of Miguel Montero Baker. This patient had an easily palpable dorsal pedal pulse, was told by his doctor that this was simply a pressure sore because he had a great pulse in his foot. ABI was actually quite high, beautiful dorsal pedal pulse. What's the problem? He's got great SFA, great popliteal, anterior tibial's wide open, perineal's wide open, posterior tibial is occluded. This is the posterior tibial angiosome, and you're not seeing good blush here. This was not going to heal. Very interesting. Skin perfusion pressure here, far too low to heal, confirmed. So we needed to get flow here, and that's indeed what was done in the vascularly, and that allowed healing of this. So does it matter? I think debating with Amir Motajameh is about as smart as picking a fight with Superman. You don't do well. Okay, he's one of the most brilliant men in the field and certainly a phenomenal debater. And I would be the first to say it's not always necessary. But I will tell you, there is a role for angiosome-directed therapy. Yes, it's clearly important when there's poor collateral flow to an area requiring ulcer healing or skin grafting. And this is most needed in diabetics, patients with chronic kidney disease, and the very elderly. With that, I thank you for your attention, and I'll invite my antagonist to come up here and shred me. Dr. Motajameh.
Oh, Greg, you didn't give me anything to debate with you. You took everything out of my hand. Well, the angiosome, Greg, mentioned that in detail and very nicely, but altogether is a block of tissue supplied by a source artery. That is not that important as much as the angiosome are linked together by numerous collateral arteries. And I have to thank Jaafer for lending me this slide. There are also larger arterial connection and collateral arteries that allows one angiosome supply circulation to another angiosome. Well, as Greg said, the ankle and foot are divided to 6 angiosomes fed by 3 source arteries. So anterior tibial artery, Greg covered that, posterior tibial artery, and perineal artery. So perineal artery, according to angiosome and description of angiosome, is just supplying a small portion of the heel of the foot. But that's not the whole thing, Angiosome is more than, the perineal artery is more than just having 2 anterior-posterior division. 20% of populations, distal anterior tibial dorsalis pedis, evolve from the perineal artery. This is something that they don't tell you when they describe angiosome. 5% of the posterior tibial arteries comes from perineal. In 1% of our population, both dorsalis pedis and plantar arteries evolve from a perineal artery. You look at the angiosome, you think, well, perineal artery is an artery that you can live without. But is this important for you do you really have to know these things? Certainly, if you're in the business of revascularization and taking care of patients with CLI, you ought to know these things. This lady came to us because her amputation of the fifth toe was not healing. She also had a plantar sore on the second toe. And so looking at this, you think, oh, gee, you need to go and have anterior tibial angiosum and posterior tibial taken care of. Fine. We do that if we can do it. But look at the angiogram. We see the angiogram. The only thing is really workable is anterior tibial artery. Now, are you going to recanalize this anterior tibial artery? Take the advice of the angiosum. Look at it again very carefully. The distal recanalized section of the anterior tibial artery looking inward, it's not going straight up where the anterior tibial artery is. What does it tell you? It tells you that this is coming from peroneal artery, not from anterior tibial artery. If you try to recanalize the anterior tibial artery, you have a disastrous complication of bleeding and maybe compartment syndrome. So you go after the peroneal, as I did with this, recanalize them and do an atherectomy on them, and you get a result like that. So you ought to know these things. Here is another case example of the posterior tibial artery evolving from peroneal. If this patient probably, the way I look at, never had posterior tibial artery proximally. The distal posterior tibial artery evolves from the peroneal. So you go and take care of that peroneal artery and restore circulation to the foot. No patient with CLI has intact angiosum. This is good for anatomy book. And if it is possible, well, of course, we all know. We know the anatomy. You don't need an angiosum. You know if you have ulcer on the dorsum of the foot, you have to go after anterior tibial artery. But not always the source artery is amenable to endovascular recanalization. Therefore, you have to play with the hand that you dealt with. Here is a 90 years old lady with a history of the CVA, and it has ulcer on the heel of the foot, so we need posterior tibial artery. It has ulcer on the lateral side of the forefoot. We probably need anterior tibial artery. Fine. If we can get them, that would be great. But look at the angiogram. Diffuse disease of SFA popliteal artery, occlusion of the popliteal artery, and as far as the distal runoff concerned, no posterior tibial artery, anywhere you can work with. And peroneal, the trunk is occluded to peroneal artery. That makes sense to go and recanalize that. But look at the anterior tibial distribution. The anterior tibial artery is diffusal disease and distally occluded. But on the other hand, you have something that you don't see in a lot of the other patients. You have a collateral artery that is as good as a bypass surgery. This is bypassing proximal anterior tibial to distal anterior tibial artery. You ought to respect that collateral. Yes, I can go and recanalize the anterior tibial artery at the cost of losing that collateral. But one way to serve this patient is to preserve that. Here we recanalize that right into that collateral artery. Although I have my wire in anterior tibial artery, which I could have very naturally recanalized that, I didn't, because no matter what you do to anterior tibial artery, in this case recanalizing, it comes back with restenosis and reocclusion. But that collateral artery never goes down. Collateral arteries don't get diseased. like regular artery. So all I did, I rechannelized the popliteal artery into the collateral artery, and I restored the circulation. And here is 30 days after that procedure done. That huge ulcer is totally healed, and the heel ulcer is healed. And patient never had posterior tibial artery. So angiosum is a theory. It's good for the book. It's good for anatomy book. In reality, might not really work for you. This is another patient who's 81 years old, full history of arterial disease, carotid endarterectomy, multiple leg procedures, and a graft between his popliteal and peroneal artery because that's the only option he had at that time. Now he come in with all this ulceration, both on anterior and posterior side of the toes. And so now we have two angiosomes that we have to work with. But he had an arteriogram, and his vascular doctor told him, that's it, that's the end. There is nothing we can do as far as revascularization concerned, and there is no more surgery to be done, and you have to have below-the-knee amputation. If you look at the arteriogram, so he's one way right. There is not much endovascularly possibly he can do because he has done them all. But you always have to give the patient a chance of working on all the options that you may have. When I saw that angiogram, by the history, I wasn't going to take that patient. When I saw this angiogram, I called the patient and said, come in, you have maybe a chance that I'll be able to do something for you. There is a graft there. Grafts, don't give up on grafts. Even the old graft, they are a good conduit. So what I did, I went after that graft, rechannelized it, did a selective arteriogram, put a distal protection device, 3 millimeter distal protection in the peroneal artery because that's the only thing he had. Then I dilated that with a 3 millimeter, 4 millimeter balloon, and this is what I got. A big, approximately vein graft with a small aneurysm, but distally, this graft is very poor and looks like it has some thrombus in it. So I did an angiojet, clean up the whole graft, but still have a very poor graft. If I leave this graft, it's going to get thrombosed very soon. So in order to preserve those distal collateral arteries first, I put an expert stent in to keep that collaterals intact. Then I put a 5 millimeter Viabon through that, and a 6 millimeter Viabon above that, and I had a very nice bypass to his peroneal artery. You might say, well, there's only a little peroneal artery, but when you give them arterial inflow, all those collaterals over time is going to get large. And here is that picture was taken Monday, this past Monday in my office, 30 days after the other picture. And so he's healing, he's improving, and I have an anticipation that saving that leg totally. In summary, angiosum is a collection of color pictures superimposed on anatomical distribution of distal arteries. Those who have knowledge of lower limb anatomy and its variation have no need for angiosum, and those who have to be guided by angiosum may be insufficient in management of patients with severe distal vessel disease. Thank you.
As always, a great, you never want to debate Dr. Mohtashemeh, but the truth is, I think we probably are in total agreement. I think if we get off of the debate scene, he would agree you need to get blood flow to that area that's ischemic. I would also say to try to just simply get that one vessel is ludicrous.
But
And so I think the
I don't
truth
think,
is-
Greg, you said anything different.
Yeah,
That's why I said, you know.
we do exactly the same. And so that's exactly right. I think it's important to understand the concept, to shoot for it when we can. But as he said, sometimes it's not reasonable. And we have to look at the collateral flow. And you could see in those cases, he was going to get a good result because you saw nice collateral fill. You could see in the case of that heel ulcer, that was not going to heal because there was no blood flow there. And I think it's not as hard as people try to make it seem. Yes?
How much, Dr. Walker, you do revascularization from popliteal to collateral rather than the
Have I
native
ever done
vessel?
that? I've done it in a couple cases. Actually, in a blind segment, surgical revascularization in the past actually had better results than people thought. It was using that same basic concept that Amir brought up. And he's right, that the diameter of that collateral was about as big as the other vessel, and the restenosis rate in 20 centimeters of total occlusion is pretty high. I think that's a very reasonable approach, and I have done this as well. So with that, if we can go back to Jack while we have a second. Jack, can you hear us? Dr. Chamberlain,
all
can you
done.
hear us? Okay.
Can you see our picture there? Do you have it?
Yeah, that looks pretty darn good. Tell us what you did.
Yeah, so we took your advice. We brought down a 2.5 balloon down past that last lesion and into, not sure which one of the plantar branches, looks like the medial, and did a 2-minute inflation. It looked much better, and we left it alone.
Beautiful. Beautiful. And
That's great.
do you have any images further down? Just looking to see, does this reach across and connect?
I know. As far as, let me play it all the way out. I'm sorry I didn't go out to
Okay.
the bottom of the foot there.
No problem.
He's almost off the table.
He's a tall dude, huh? Much better.
No, we're done, and he wants to go home.
Oh, I got you. That's that kind of off the table. I thought you meant he was that tall. Beautiful, beautiful result.
But yeah, I'm sorry. Yeah, doesn't it?
I think if I were he, I might want to get off the table as well right now. I think that looks good. Any comments from the panel? No comments? Jack, thank you for a spectacular case. Really great job. Lovely example of what can be done here. It's indeed my pleasure to invite Dr. Mohammed to come up here. He's going to show us a complication and disaster case. You know, I was once asked to give these, and you know, it's interesting, when you go back through your files, you realize you take a lot fewer pictures of your disasters than you do of your good cases. And so sometimes it's not so simple, just this top button right here. Thank you for having the intestinal fortitude to get up and show this. Thanks.
Thank you, everybody. I'm going to present two fast cases about complication of peripheral intervention that if they were not treated right, there will be disasters. It's not, So 48-year-old, history of hypertension, diabetes, hyperlipidemia, tobacco use, had multiple revascularization, endovascular revascularization for peripheral arterial disease, had Rutherford classification 3 in the visit to the office, symptoms on the right side more than the left side, non-invasive Doppler ultrasounds show severe bilateral superficial femoral artery disease, went to the cath lab for elective peripheral angiogram with possible intervention to the right lower extremity through the left common femoral artery axis. As I mentioned, past medical history, past surgical history, multiple revascularization, no known drug allergies, multiple medications, including diabetic hypertension, aspirin, Plavix, history of coronary artery disease, active smoker, physical exam outside the leg exam is very normal. The Doppler ultrasound shown significant lesion in the mid-right SFA and distal left SFA. Patient underwent peripheral angiogram, which showed, I'll come to show the pictures, but it showed left common iliac stent, which is patent, 90% mid-left SFA stenosis, and 100% CTO of the mid-right SFA, 3 vessel runoff below the knee bilateral. Now, how do we play the video? No.
Can you help Dr. Hamden in the back? Can you
Can you go
actually
back?
play his video on the one before?
So bilateral common iliac artery with a stent which is patent. Can you go back to the previous picture also? Yeah, can you play it? So left SFA had mid 90% lesion. Next. Now here? Yeah. Can you play it? So the right SFA in the mid segment had, next one please, had chronic total occlusion. We can see that there is 3 vessel runoff below the knee. So the chronic total occlusion was crossed with using 0.018 gold tip wire with the supporting catheter 0.018. The lesion was treated with orbital atherectomy device, diamond back, 2O solid. Then there was balloon angioplasty performed using 5O by 300 ultraverse. So that's the CTO segment in the mid SFA. Next, please. Yes, revascularization using atherectomy device. Next. Successful revascularization of the SFA. Now next.
Do you routinely look downstream after? Okay, I was going to ask, because I routinely do that after a chronic total, look downstream to make sure there's no embolization.
And that's what we see here, that there was distal embolization of the below the knee vessels. And we still have the wire in the peroneal. So can you go back to the previous one? Yeah, can you play the video again? So the purpose of the case is to present how do we treat the distal embolization after atherectomy of the SFA. And in this case, we had to wire the anterior tibial and the peroneal. We did manual atherectomy of the both vessels, and then we did balloon angioplasty of both vessels, and we regained the flow in the below the knee vessels again. So the post-intervention, no flow distal to the right popliteal artery. Wire was in the peroneal. Another wire, we used the run-through wire to wire the right anterior tibial artery. Aspiration atherectomy was performed in both arteries, peroneal and anterior tibial. Then balloon angioplasty. We give integralin, nitroprusside, nitroglycerin intra-arterial injection, and then there was TIMI-3 flow. What's your input about giving nitroprusside and integralin, like local integralin intra-arterial?
Yeah, that's a great point. To start with, let's talk nitroprusside. Nitroprusside is very good when you have capillary embolization. It seems to help there. This is trifurcation. This is bigger vessels, and this is a big embolus that you've got here, and could be clot, could be old organized clot, or it could be atheroma. And so this is a little tougher situation. I think you'd get very little benefit from giving, for instance, nitroprusside here. I think that giving integralin can be useful if it's clot, especially if given in very high concentrations. There's data that 2B3As given in extraordinarily high concentrations actually exert a bit of a thrombolytic effect locally without having that same effect throughout the whole body. And so that is something we use. And if nothing else, it may buy you time to go in and extract this. You know, it's interesting. My great friend Eric Dipple, if he were here, would say, this is why we need to use a filter all the time. And I would then add to that, that's why we need a better peripheral filter than we have. We're trying to adopt carotid filters and other things which aren't so good in the periphery. They're too expensive. They move. The basket's not big enough. If we had a cheap filter that was big, I think we'd routinely use them because embolic sequelae occur with all forms of interventions. I've heard many of the companies get upset when people use distal protection, but they shouldn't. I mean, distal protection is, whenever you have this kind of atheromatous volume, there's a chance of knocking some of it distal. And so if we protect against that and stop that from happening and then can treat the patient, that's a win. And so I think this speaks volumes for why we need better distal protection tools made really for peripheral interventions that are not so expensive as to negate the ability of us to use them. Any comments from the panel?
I mean, I agree. Every time I atherectomize with directional atherectomy, 100% of the time I use a filter, and 90% of the time there's something in the basket. I've used the NAV6 for long CSI runs and common femoral work, but again, it's clumsy, you know, it's hard to use. But protecting it would prevent the next 2 hours of extraction here, you know?
How often do you get debris when you're using, let's say, a grinder of sorts? Either one.
How often do I, say it again? How often do we debris?
Yeah, if you're using CSI, you know, to grind, it typically gives small debris, but
Yeah.
but in all case, I don't care what device you use. Laser gets it, balloon has it, wires even have it. All things can create debris. I'm not picking on one company. I'm just saying debris occurs. How often do you see it? Is it?
You know, I think of the runoff before I pick the device. I want to make sure there's not a lot of small microvascular runoff. If there's bigger macrovascular, I feel more comfortable with the CSI, but I've seen it a lot with that, and I, you know, but with the basket, with a directional atherectomy, I see it every time almost, and I feel very comfortable using the basket, and I retrieve most of it, so.
PK, your comments?
Mohammed, I think it's a great case. I just want to comment on two things. One thing we do at Sinai is if we watch how the wire passes, in a chronic total occlusion like this, if the wire was really slick, I'm sure, and just went through, then you would think it's thrombus. And you kind of anticipate what it is that's distally embolized. Obviously, like Craig said, you can never tell. You probably have thrombus with atheroma, but what's the predominant flavor that's down there? So if we felt it was just thrombus, I mean, if it was thrombus, then obviously we would do lytics or 2B3A or whatever it may be. But if we felt it was atheroma, it would just be aspiration.
Amir, any comments here? Because you have such a wealth of experience with this, and you and Tom taught us the whole field of thrombolysis as well. Any thoughts about this particular lesion and this ultimate embolic complication?
Are you asking me?
Yeah, I am.
I have nothing to say at this time.
I think that means he wasn't paying attention.
Would like to go to the next case because
Okay.
we have to close.
Okay,
the-
then let's go on to the next case if that's possible.
Okay.
Yeah.
We're actually go to the next speaker, so we can do, because we need to wrap it up.
So next we have Dr. Zaidi. Transradial PCI complication.
So I want to thank everyone for having me here. I feel sort of like a fish out of water. I don't do much pedal work, but this is my sort of area of expertise is transradial coronary intervention. So I'll try to go through relatively quickly on a complication that we've had. I want to thank my fellow for actually preparing this case that we presented at one of our earlier meetings. These are my disclosures. So the patient is a 62-year-old woman with exertional angina, class 1 angina. Risk factors, the typical risk factors. She had a myocardial perfusion image that showed anterior and anterolateral ischemia. Here is her the coronary angiogram, and then the finding of interest was this sort of moderate-looking left main lesion. She underwent IVUS, and that demonstrated a minimal luminal area of 6.75 with a stenosis diameter of 55%. Based on that, we had recommended surgical revascularization, but she chose elective PCI to the left main. And so here's our sort of PCI strategy. We used a 6 French hydrophilic sheath after using a micropuncture access from the right transradial approach, put in an extra backup guiding catheter, used bivalirudin for anticoagulation, and used a drug-eluting stent. And post-PCI, IVUS looked appropriate, and then there's her antiplatelet therapy. And so in terms of the procedure, we had done a front wall puncture. The wire advanced very easily with really no excessive manipulations. The sheath was introduced without difficulty, and then we gave the traditional antispasm drugs that we use at our center. 6 French guiding catheter, we used an 035 wire, and then we noticed that there was resistance at the sort of the radiohumeral joint with passing of our J wire. The patient reported pain, and what I tell all my fellows is this should be a really entirely painless procedure. When patients complain of pain in their arm, you really shouldn't go any further. So the wire could not be advanced further, and the guiding catheter and the wire were withdrawn. Usually when patients have pain, we take an angiogram, and so in this angiogram you can see that there's a perforation. And I'll show you sort of kind of at the location right below her elbow joint. And so you can see there's the radial artery, then you can see the brachial artery above, and I think the arrow is not exactly on it. Right next to that artery is right up here is the recurrent radial artery, which is a very common location and a very common situation where patients, or a location where people get perforations in their radial artery. And so we sort of try to magnify it, but it's, again, relatively poor resolution. I think sort of like you said, we don't really take a lot of images when we have complications. We kind of try to hurry up and correct the complication before patients have anything significant. So here what happened was the problem was we tried to cross the perforation with a wire, and we were unable to do that. We did stop the bivalve infusion, and then we moved the radial sheath. And then we put the TR band on. And so what the problem that happened is that we immediately put a blood pressure cuff over the perforation site and inflated to 20 millimeters of mercury above her systolic pressure, and placed a pulse ox it had an uninterpretable waveform. And then we did note the ACT was significantly elevated given the bivalve infusion. And the patient said that she couldn't feel her fingers. We had disappearance of capillary refill with marked expansion of the forearm with a visible hematoma. Patient had significant pain, bradycardia and hypotension requiring atropine and saline bolus. So we promptly contacted vascular surgery, who took the patient emergently for a right arm fasciotomy, an exploration of the right forearm with repair of the radial arteriotomy, a thrombectomy, and a vein patch. And so the time to complication, if you can see that everything happened relatively quickly. Arterial puncture bivalve at 5 minutes. The perforation was diagnosed at 8 minutes. Blood pressure cuff was up 6 minutes later. And then within, another 31 minutes after that, the patient was in the O-arm. So things moved relatively quickly. Patient made a full recovery, was discharged on hospital day 4. They were able to do a relatively minimal, a relatively small incision on her forearm. And then she underwent uncomplicated PCI via the femoral approach 2 months later. Now, just in contrast, we have another patient, again, very similar issue, and I won't go too much into all the details, but really what happened here was very similar front wall puncture, antispasm drugs. We gave heparin, and again, patient had resistance to the wire right at the same location, reported pain, and then we did selective angiography, and really what we saw here, very similar. You can see the perforation right there, right in the forearm. And so what we did differently here was we were able to, I'll go fast forward through this. We were able to cross the lesion with an 014 coronary wire, and then we took a 6 French diagnostic catheter and basically crossed the catheter, completed our angiogram, and then about 45 minutes later, we took another picture. And you can see that it healed. And so that's really the teaching point here, is that when you have radial artery perforations, they're rare. They happen in elderly patients, women more commonly, tortuous radial arteries. But really, with the sheath in place, if you diagnose the perforation, the key here, and what I tell all my fellows and interventional fellows, is try to keep your wits about you. Don't take everything out. You really want to try to cross this perforation as quickly as possible with a wire. And then once you're across that perforation, you want to put a catheter across that perforation. And in the beginning, if it's a little bit too scary for you to complete the intervention or go ahead and proceed with the intervention, that's very reasonable. You can leave the catheter there for 30 minutes, 45 minutes, and then take a picture. That's fine. A lot of people, and myself included now, will go on with our diagnostic procedure, our coronary intervention, give anticoagulation, finish the procedure, and within half hour and 45 to 45 minutes, the perforation will seal. We'll always take a confirmatory angiogram prior to removing the sheath. Now, what you do here's a classification system that you can find in the literature that was proposed by Olivier Bertrand from Montreal, which has a sort of a classification. In the interest of time, I'll just leave it up here. If any of you are interested, I can help find it for you. It was published in Circulation in 2006. And then here's what you do for after you remove, if you have the sheath out. So here's one of the suggestive management strategies: that apply a pressure cuff at the site of induration, inflate the cuff to just below the systolic pressure for around 15 minutes, monitor arterial flow with pulse ox, and adjust the cuff pressure so you have a signal. And you can see this is not exactly how we did it in the first case, which I think probably contributed to some of the problems that we were having. Try to manage pain and hypertension. Consider probably significantly, I would probably stop anticoagulants. Consider protamine if heparin's in use. And then if persistence of swelling, pain, or induration after 2 inflations, consider urgent surgical consultation. And that's it. Thanks.
Thank you for a great talk. I see we have a question from the audience.
Yeah, we use radial all the time. I usually use the left radial. I guess you use the right radial more often. I think most often we get into this problem if your arm is bent a lot. If you bring your arm all the way up, bending the arm actually sometimes creates a kick. And if you're pressing the wire up, if you just use the 035 regular wire, sometimes that wire goes into smaller branches. If you keep on pushing, it creates a rupture. If you use a versicore wire or even 035 Terumo glide wire, that probably will take you up. And giving heparin once you are at the arch of the aorta, not beforehand, I think sometimes can prevent the excessive hematoma formation.
Yeah, no, I think those are excellent points. I think we typically do all of our cases, 80% of them from the right approach. When we do left approach, we try to keep the arm straight just for that reason. We've begun, especially with my junior faculty members who've started and we're just learning how to do the radial approach, we give anticoagulation once we get into the arch. And so that's especially for elective interventions. So those are certainly some learning points that we've had from these cases. So, and I do agree, when it's really the identification of a loop, that's the most common cause of people having perforations. I actually don't like using the glide wires or straight wires because I think you're more likely to find these small branches. And in order to save radiation exposure, I don't routinely fluoro the arm unless I have resistance. And that's what happens that's why I like the J-wire.
Yeah, so. I think one of the things that I want to comment on is that the rate of switchover from radial to the femoral is much higher from the right side than the left side. So the tortuosity and branching is much more complex in the right as compared to left. So
okay,
if we could, I'd like to move on to our next lecturer.
All right, I know everyone's hungry, so we'll try to get you out of here. Appreciate the patience here. Is it just this arrow here? What do we push here? Green? Okay. So talks about complications and disasters, and I always find these talks the most interesting because I think you learn a lot. If you do enough cases, you'll have complications. If you have no complications, you're either lying or you haven't done enough cases. Knowing how to handle the complications is the most important part of that complication. And I've got 5 rules in the lab, and when we're talking about disasters, we could go into detail about the Brazilian effort yesterday, but we'll lay off. Keep yourself calm, keep your staff calm, keep the patient calm. Sedation is your friend. Use your colleagues. When needed, 2 heads are better than 1. And quickly develop the plan and fix the problem. When it comes to disasters, by definition, they're never intended, and they're not the story we wish to tell our patients. In the end, it's our toughest times that we learn the most, and it's conferences like these that allow us to take away from these types of cases. So this case is about thinking outside the box. 61-year-old carpenter comes to see us. He's had about a 6 to 12-month history of claudication. Pain in his left leg worsening at rest over the last 3 weeks. ABI's down at the hospital. Right leg's normal, left leg 0.47. He's got a history of hypertension, hyperlipidemia as a smoker. He had a knife injury to his left groin as a child, which was repaired. His pulse exam is diminished in the left pedal vessels as well as popliteal. We get a CT in the office. And you can see here, I think they inverted the image. But that's unusual. With the image here and the CT scan, actually what is upside down here, though, on the patient's left leg here, there's a popliteal occlusion. If you look closely, you can see that there's an aneurysmal segment of that portion of the vessel. And this is just a more zoomed view. comes out a little better on regular presentation size, but again, following the artery down, you can see that it becomes occluded, and there's no patency there in the vessel. And as you run below the knee, he's got 3 vessel runoff. So CTA documented 5 to 6 centimeter segment occlusion. It's about 9 millimeter. It looks thrombosed. We brought him in for conventional angio, intention to place a TPA catheter for lytic therapy, and our initial angio is here. Okay. Any way to play that for me? You try that again. Bring the cursor down. Push play. It's worked before. Try that again for me if you could. Why it's not doing that? Well, we'll try to move on here. Not sure what's... the angiogram shows us that the popliteal space is occluded. We did have good collateral, genicular collaterals to below the knee space. 3 vessel runoff was present. We had certain options here, whether it's percutaneous surgical, do more imaging. The question of how to approach this percutaneously, we chose to drop a TPA catheter through a 6 French sheath up and over. Ran some heparin overnight, 1 milligram an hour TPA. Labs were appropriate, came back the next day, and here's our angiogram. Can you try to play that for me? Okay. I'm not sure why it's not playing
It
here.
didn't work. I had the same problem.
Did you?
Yeah.
You know, it played in the prep area. Well, so what we saw in this image here, which you can't see, is the patient had a popliteal aneurysm. He had recanalization of the vessel with the TPA, and he had 2 focal lesions with about 80% stenosis. We decided to perform directional atherectomy here, and if you'd seen the image, I might ask the panel what they might do with these lesions, but we decided to proceed with directional atherectomy. We had several runs with a Silverhawk, used a PTA balloon 6.0, 3 minutes, 3 atmosphere pressure, and had some final angiographic results, which we'll try to play again.
So you had a thrombosed popliteal aneurysm at first, is that correct?
Say that again?
So you think you had a thrombosed popliteal aneurysm?
We did, yes. Okay. And the CT imaging supported that image. We actually got a really nice balloon angioplasty result. We decided because it was aneurysmal, we would do some clinical follow-up and also do CT imaging follow-up. So at 9 months, he had complete resolution of claudication, little persistent edema. Venous and arterial Dopplers were ordered because of the edema. ABIs were normal bilaterally. The venous Dopplers were without thrombus, but there was comment on the popliteal aneurysm. It was made that there was intimal hyperplasia noted, and it was non-calcified. So we did serial CTA here. Again, for reasons unbeknownst to me, it's been flipped. And if you follow down, this is our aneurysmal segment. And as we get into the retropopliteal space, you can see it's become much larger. It was 9 millimeters, and now we're getting about 2.2, a larger image of that. And coming down, we've got expansion of the aneurysm here.
On your initial angiogram, after you'd lysed, did you have good vessel runoff, and would you have had a landing zone if you would have wanted to have put a Viabond stent? Would you have had enough room?
Yes. We had an excellent runoff, and yes, I think we could have.
Yeah. I'll tell you, whenever I see a thrombosed popliteal aneurysm, my treatment would be to lyse first, to balloon aggressively, and if I have a landing zone and good runoff, to put a vibe on. I think that, you know, here what's happened is you've repressurized this zone. I think expansion, you see it. Rethrombosis can occur. It's happened once. What would be your approach, Amir?
Well, if there is no complication to thrombolysis, that would be my first choice.
Yeah. Mm-hmm.
Yeah.
Yeah, and so that's what we're learning on this as a complication, perhaps, from atherectomy in this aneurysmal space, is that potentially we, made the competency of the wall a little bit weaker and it started to grow. So we have this now, and again, we went through the same kind of workup. Should we perk? Should we talk to surgery, further imaging? So we plan to bring them in for a Vibon here. Again, the cath films. This is the same second verse, same as the first. Probably going to happen again, which is a bummer because these are pretty good images. But we had a very obvious aneurysm, increased in size. We decided to do the Vibon. This is our Vibon pre-implantation. And we actually used a 7x10 and had excellent 1 to 2 centimeter coverage north and south of the aneurysm sac. And hold on, don't touch it. It might play. Let's see.
Yeah. Our experience with Vibons here has been pretty good. If you can really dilate that stenotic segment up very well, they've really been, I think, equivalent to surgical revascularization. I really think they work very well right here.
So we got a great result. We were very happy. We had we had perfectly sized by CT data. You know, we had a nice runoff. So, gentlemen, continues to have an excellent pulse exam. No claudication. However, in about 3 months down the road, he develops a DVT, a little bit more swelling. So he was then put on anticoagulation with warfarin. He was seen by a hematologist. Hypercoagulable workup was negative. We did a follow-up CT plan 6 months down the road from our Vibon. And the patient was also complaining of some distal thigh pain now. And this is our serial imaging on our CT follow-up. You can see now, this is appropriately flipped. Here's our left our leg here. We have popliteal space. The space around the Vibon now is expanded and actually looks more aneurysmal now than it did before. And there's actually collaterals that are kind of seen going into the aneurysm sac there. So at this point, we discussed this further with our surgical colleagues. We're getting a 3.4 by 3.9 centimeter aneurysm now with contrast external to the Vibon. So we had concern for type 2 or type 5 endoleak with possible endotension through the Vibon. So what do you do now? Any thoughts? He's been on aspirin and Plavix, but no. We did 6 months of warfarin, and then no, I take it back. He was still on warfarin at this time. He was still on warfarin this time because he had the DVT.
And you feel like you've completely covered the aneurysm proximally?
We did. If I could show you the picture, you'd probably agree. It looked really nice. Great apposition of the Vibon.
There's a question from the audience. Someone was?
We did. We did. We used a 7.0 device, but used a 6.0 balloon for post-dilatation. Yes. Fair. Good thought.
Well, let me understand that you have a Vibon for popliteal aneurysm. Now you have endoleak. Is that correct?
That's our concern.
Okay. Where is the upper level of Vibon?
Upper level is probably proximal popliteal distal SFA.
You know, in treatment of the endovascular treatment of aneurysm, it's not important that how big the aneurysm is. The important thing is the landing zone below and above. So if you have an endoleak, you might be able to extend your Vibon up to a level that fits your Vibon very nicely. That should stop the endoleak.
Mm-hmm. What do you think of the collaterals that we're seeing on the CT into the vascular space? I mean, they developed in the presence of an occlusion, and we're seeing them filling the aneurysm.
Well, the endoleak in the leg, in the popliteal area, is not like endoleak in aortic aneurysm. The mechanism is not the same. Collateralization is not the same.
Yeah.
If you put the vibe on above the traffication up to a ductal canal, you practically have no collateralization.
Sure.
So if you have an endoleak, it is from the artery itself. It's not from the collateral arteries. So if you extend it up to a level that vibe fits very firmly with the artery, and then you should
Yeah.
be okay.
I agree with that. The other difference between this and an abdominal aortic aneurysm is you're not worried so much about this rupturing. You're worried about this thrombosing or causing pressure events like it did on the vein. And so I think if you go up high enough, you typically can reseal these. That's why I was asking the question earlier, did you feel like you had covered the entire aneurysm? And that question is not just angiographically. Keep in mind, in every aneurysm, there's laminated thrombus. I don't care what kind of aneurysm it is. Every aneurysm has laminated thrombus. And I think a very important part of treating any aneurysm is to do confirmatory IVUS when you're done. And I can tell you, at least in my experience, I've often thought I've really covered everything, and I've missed a lot when I do IVUS. Has that been your experience as well?
It is. I share that experience.
That's an excellent point. So another image just up close of this aneurysmal segment. You can see us coming down. Our Vibon is there, and then again, about 3.4, 3.9 aneurysm around it. So we did discuss this case by vascular surgeon, did an MRI, confirmed that there was collateral flow into the aneurysm sac. They were concerned for a type 2 endoleak. Surgical exploration was planned with possible bypass popliteal artery. You know, data supports there is endoleak. 6% of cases with Vibon are going to evidence this. So our surgeon got in. Extensive inflammatory and dense desmoplastic reaction was noted on exploration of the popliteal fossa. Sural and tibial peroneal nerves were plastered to the aneurysm sac, probably causing his thigh pain, needing to be meticulously peeled off. 4 to 5 branching vessels were identified feeding into the sac. Popliteal artery was adherent to the vein, needed a complete resection. Dense intimal hyperplasia was noted in the distal end of the Vibon stent. And 8 millimeter ring PTFE was interposed with good anastomosis, good distal pulses. Intraoperative aneurysm sac vessel stent sent for pathologic review. The path comes back concerning for a spindle cell tumor, showing large cells with prominent occasionally eosinophilic nuclei, set in the background of marked fibrosis, chronic inflammatory cells, and occasional PMNs. Positive for certain markers. Differential included this. Path was reviewed at U of C Mayo and Mass General. This was a spindle cell tumor type confirmed. Final diagnosis seen was a poorly differentiated malignant fibrohistiocytic sarcoma. PET scan was done, showed that the patient had hypermetabolic tissue uptake in the calf and ankle. And he subsequently went for an AKA.
Wow, what a case.
So a little bit on spindle cells. I'm going to breeze through this because this is kind of snooze stuff, but the reality of this case for us was pretty educational. So what did I learn? Sometimes when you think you've seen it all, you haven't. Think outside the box. An aneurysm in isolation might raise concern of other diagnoses. Patients tend to be symmetric. Consider sending a sample of the tissue you collect from atherectomy for pathologic review. I don't think I ever do it, but consider it. And a comprehensive approach to patient care involving multidisciplinary approach offers the most complete care we can offer for our patients. And I apologize for the AV misfire there. Any questions?
What a great case.
Great case.
That's right. That's right.
Interesting.
Well, thank you.
Nice case.
Guys, thank you, and we'll close this session with that. Thank you much to the presenters. Yeah,